Hi everyone. I hope I'm audible. Hello Sai, how are you? So I'm just waiting for a minute so that everyone could join. All right. So let us begin. So in today's session, we're going to discuss few high yield images along with few flashcards, and subsequently I'll be teaching you the integrated things along with it. All right. So number one image that you have to see here is a bacterial growth curve. So you need to know that what are the different phases of bacterial growth curve and what is specific about each phase of the bacterial growth curve. Okay, so if I ask you, okay, what is specific about the exponential phase of bacterial growth curve? Can anyone tell me what happens in the exponential phase of bacterial growth curve? Yes? Anyone? Exponential phase of bacterial growth curve. Okay. All right. So let us try to understand the different things during different phases. So we have overall lag phase, then we have exponential phase, then we have stationary phase, and then ultimately death. All right. So you need to know what is peculiar about each phase here. So when you talk about the lag phase, remember in lag phase, the metabolism is high. The metabolism is high, but no cell division. So mark it that there is no cell division during the lag phase or bacterial growth curve. Then moving on to the next phase, we have exponential phase. In exponential phase, there is rapid division of cells. There is going to be rapid division of cells. All right. In case of stationary phase, what we're going to have is that the nutrients are depleted and the toxins are being built up as a result of the metabolism, right? So this hampers the growth of bacteria. So growth is slowed down in the stationary phase, and ultimately there is death. So bacteria, they are dying. So these are the different phases of the bacterial growth curve that you need to know. Okay, so this is very easy. Just remember it. Yet it is high yield. Moving on to the picture number two. This is a very famous picture. Yes, so let me see who can answer this. What is this? Anyone? What is shown in this picture? Yes? Anyone? What is shown in this picture? Okay, so the answer to this question is that these are bitted spots. Okay, so it has been asked in the recent years also. Time and again it has been asked. So this is a picture showing bitted spots. All right, so where do you see bitted spots? In which condition do you see bitted spots? Anyone? In which condition do you appreciate bitted spots? Your answer is vitamin A deficiency. Vitamin A deficiency. Okay, let us talk about one more question here. Okay, we understand that the vitamin A deficient patient will have bitted spots, the night blindness, okay, keratomalacia, but there's a condition linked with vitamin A excess. There's a condition linked with vitamin A excess. Okay, I'll give you a hint. A young female having BMI more than 30, coming to the clinic with complaints of headache and visual disturbances. So if such a patient is coming to you, what can you think about? Yes, Swatantra, you gave the right answer. Exactly, this is a case of pseudotumor cerebri. This is a case of pseudotumor cerebri. Okay, you can also call it idiopathic intracranial hypertension because the cause is not known. Idiopathic Idiopathic intracranial hypertension. Intracranial hypertension. All right. So what is this? This is pseudotumor cerebri, and in this the ICP is raised. The intracranial pressure is raised, and due to the raised ICP, the patient will have papilledema, visual disturbances would be seen, and headache would also be there. So a young fatty female complaining of headache and visual disturbances, you can think about pseudotumor cerebri. What is the drug of choice for pseudotumor cerebri? The answer to this question is acetazolamide. Acetazolamide. Okay. So what is acetazolamide? Next question. This belongs to carbonic anhydrase inhibitor. So this is a carbonic anhydrase inhibitor. All right. So would you give acetazolamide to a patient who is sulfa drug allergic? Would you like to give acetazolamide to a patient who is sulfa drug allergic? Yes or no? Anyone? And give me the reason why. So Eva Braden and Saftantra, you gave the right answer. You would not prefer giving acetazolamide to a patient who is allergic to sulfa drugs. The reason is that acetazolamide is a sulfa drug itself. All right. So in the previous lectures, I made you write the list of the sulfa drugs. So learn the names. So if you are being given a condition in which the patient is allergic to sulfa drugs, you're not going to give acetazolamide. All right. Otherwise, you will induce the allergic reaction in such a patient. Moving on. Look at this picture. Yes, what is shown in this picture? This picture is very high yield, guys. Please know this. What is this? Good. So you guys gave the right answer. Swatantra, then Sonali, Angad, Reformer. Yes, exactly. So first of all, if I ask you what is shown in this picture, you're gonna answer it as a Burbeck granule. This is a Burbeck granule. Okay. What is the appearance resembling? This resembles a tennis racket. So this is a tennis racket shape. Tennis racket shape. Okay. Next question. In which condition would you see this type of electron microscopy picture? Your answer is Langerhans cell histiocytosis. The answer to this question is Langerhans cell histiocytosis. So look here. We are looking at the Burbeck granules. They are having tennis racket shape. All right. And this is seen in Langerhans cell histiocytosis. Okay. I'll ask you another question here. Langerhans cells are the modified dash. How would you answer this? Langerhans cells are a type of modified. Anyone? Modified. Your answer to this question is dendritic cells. Dendritic cells. Second question. What are dendritic cells? And ultimately, what are Langerhans cells? Exactly, Angad. Yes, the right answer is that these are antigen presenting cells. Antigen presenting cells. Your homework is to know the names of other antigen presenting cells, all right? So examples are Langerhans cell, dendritic cell, then monocyte, macrophages, B cells. These are all the examples of antigen presenting cells. Know this point. Moving on. Yes. What are the IHC markers for Langerhans cell histiocytosis? So I have marked there the two question marks here. So which one would you mark here? What are the IHC markers for Langerhans cell histiocytosis? The answer is yes. CD1A and S100. Okay, CD1A and S100. Remember these IHC markers for Langerhans cell histiocytosis. So I saw this patient myself. She was a female who come to the ortho OPD and she was having a rib fracture. So although Langerhans cell histiocytosis is Just a second. Although we say that Langerhans cell histiocytosis is common in case of children, but still it could occur in the adults also. Okay, and this female came with the rib fracture and she was not giving any history of a particular trauma. So with minor trauma or without any precedent history of trauma, if the patient is having fractures, okay, then you need to evaluate that patient according to the age group, and you need to look for the metastasis, or you need to look for multiple myeloma. All right, so there are different differentials. Now here this patient came with a rib fracture, and ultimately investigations were being done and she was diagnosed to have Langerhans histiocytosis. All right, now look at this picture. What are you seeing here? Anyone? In this picture, what are you seeing? This is a very famous picture, so you need to know about this. There's a picture that shows clue cells. This is a picture that shows clue cells. Okay, and clue cells, they are seen in case of which condition? And what are these clue cells? So, vaginal epithelial cells studded with bacteria. Okay, these are known as the clue cells. So if you see vaginal epithelial cells, they are being studded with bacteria. And clue cells, they are found in case of bacterial vaginosis. You guys gave the correct answer. So these are the vaginal epithelial cells studded with bacteria, and they are the part of the bacterial vaginosis. All right. The organism that is responsible for causing the bacterial vaginosis is Gardnerella vaginalis, and the patient will give you a history of a vaginal discharge, which is giving a fishy odor. All right, so these are all the important keywords. Then we have something known as M-cell criteria. M-cell criteria is for the bacterial vaginosis. Number one, presence of clue cells. Number two, vaginal pH more than 4.5. Number three, fishy odor that increases after the administration or adding 1 to 2 drops of 10% potassium hydroxide. All right, so this is known as the positive whiff test. So these are the three conditions included under the M-cell criteria. Know this. Moving on to the next picture. Okay, one more question here. What if the patient comes and tells you that the patient is having curdy white vaginal discharge? Curdy white vaginal discharge. What would you answer? What would you answer here? Curdy white vaginal discharge. Yes, exactly. So that is vaginal candidiasis. Candidiasis. Remember this point. All right. Look at the next picture. So this is the USG ultrasonography. This shows this appearance. Okay. Now what do you think it is? Exactly. Shubhadeep, Gurjeet, you gave the right answer. This is H mole. Hydatiform mole. And which appearance is this on ultrasound? This is known as the snowstorm appearance. Snowstorm appearance. All these images have been asked in the previous years. So know these, all right? So you know, snowstorm appearances is seen in case of H mole. H mole is of two types, complete mole and partial mole. In complete mole, as the name itself is suggesting, we will only have molar tissue. In partial, we will also have fetal tissue. All right, so it's a homework that you please know the difference between complete and partial mole. This is very, very high yield. The difference between complete and partial mole. All right, let us move ahead now. Okay. What if you are given a question like this? That a patient comes to the OPD having a rash that gives a bullseye appearance, and the patient also is showing signs and symptoms consistent with the facial nerve palsy. What is this? Gurjeet, you gave the right answer. Exactly. So, Harshit, this is not nephroblastoma. Okay, nephroblastoma is Wilms tumor. All right. This is Lyme's disease. Lyme disease. Now, what is Lyme disease, guys? And what is this rash that I'm talking about? What is this rash known as, which is giving the bullseye appearance? Yes, exactly. The answer is erythema migrans. Erythema migrans. All right, know this point. Now, when you talk about this Lyme disease, who is responsible for causing Lyme disease? Which organism? The answer to this question is Borrelia burgdorferi. Borrelia burgdorferi. All right. Moving on to the next question. Yes. So look here. What you are seeing in this question. Yes. So supposing such a type of patient is coming to your OPD, what you are able to see here? Anyone? The answer to this question is that you see this is clavicle, and above the clavicle there is a swelling here. Okay, there's a protrusion. Now, if this is particularly on the left side, okay, left supraclavicular lymphadenopathy, and when you palpate this lymph node, this is feeling very hard to touch. Okay, so this is known as the Vercoe's node. This is a Vercoe node, that is left supraclavicular lymphadenopathy. What is the importance here? If Vercoe node is present, this indicates that someone is having GI malignancy, because this occurs as a result of metastasis from GI cancers, gastric cancer, for example. So this indicates GI metastasis. All right, moving on. Yes, look at this history now. A patient coming to the OPD with bilateral renal cell carcinoma, pheochromocytoma, and hemangioblastomas. So what are we talking about here? Bilateral renal cell carcinoma, mark it. Usually cancers, if they are not associated with any syndrome, they are usually unilateral, right? So kidneys, we have two kidneys, and obviously unilateral renal cell carcinoma is possible without the syndromic association. But here, if you see bilateral renal cell carcinoma, you would think about a syndromic association, and you guys gave the right answer. No, this is not Wilms tumor, guys. Why do you think it's Wilms tumor? Wilms tumor is nephroblastoma, child having abdominal mass, right? And ultimately associated with the three syndromes, that is Danish-Dish, Beckwith-Wiedemann, and Weger syndrome. So this is not Wilms tumor. Bilateral renal cell carcinoma, pheochromocytoma, and hemangioblastoma. This indicates VHL, von Hippel-Lindau syndrome. All right. So remember, we are talking about VHL, von Hippel-Lindau syndrome, the deletion in the VHL gene, associated chromosome number 3. Similarly, guys, if I change the wordings in the question, bilateral acoustic neuromas, bilateral acoustic neuromas, what will be the answer? Bilateral acoustic neuromas, what will be the answer here? So here again, you see that this is bilateral. The tumor is there bilaterally. Exactly. The answer here is NF2. Okay, someone is giving the answer schwannoma. Gurjeet, schwannoma is the other name of acoustic neuroma, right? And this bilateral acoustic neuroma or bilateral schwannomas, they are seen in neurofibromatosis type 2. Neurofibromatosis type 2. Which chromosome is associated with NF2? Very high yield. Yes, this could be a hint to you. Chromosome number? Yes, which chromosome associated with NF2? So NF2 is having 2. So chromosome also starts with 2. The answer to this question is 22. 22. Similarly, if I ask you which chromosome is associated with NF1? Neurofibromatosis type 1. NF1. So the answer to this question is, it is starting with 1 again. 17. Yes, Sai, you gave the right answer. Okay, so easy way to remember is NF2 is ending with 2. So the chromosome name will start with 2. NF1 is ending with 1, so chromosome will start with 1, that is 17. Okay? In which condition would you see cafe au lait spots and multiple neurofibromas throughout the body? Yes? NF1 or NF2? Yes? Multiple neurofibromas and cafe au lait spots. Which one would you mark? Yes, Samprita, you gave the right answer. You're gonna mark NF1. Okay, NF1. Moving on, look at this history. Look at this history. Yes, so the patient came to the OPD. The patient is already a diagnosed case of prolactinoma. Is now the patient tells you that, doctor, I had episodes of hypoglycemia. On further investigation, it was found that patient is having parathyroid adenoma. Yes, I'm waiting for others to answer. So tell me the answer here. This, the answer to this question, the topic has been asked in the previous year. Okay, so no, this is a very high yield topic. So this, yes, you guys gave the right answer. This is MEN1, multiple endocrine neoplasia type 1. Okay, so there's an easy way to remember MEN syndromes. How you will do that? So overall, guys, when you talk about MEN syndrome, this is divided into two main types, MEN1 and MEN2. MEN1 and MEN2. MEN2 is further divided into MEN2A and MEN2B. MEN2A and MEN2B. MEN1, you will remember 3 P's. MEN2A, 2 P's, 1 M. Alright. In case of MEN2B, you will remember M3. M3. Okay. So let us talk about the components. This is very high yield topic. You must know this. Alright. So moving on, this MEN1 is having 3 P's as I told you, and it is associated with the MEN1 mutation. MEN1 is a tumor suppressor gene. Know this. Then first P is for pituitary tumor, and the most commonly pituitary tumor associated with the MEN1 is prolactinoma. As I gave you in this question, this is prolactinoma. Alright. Then the second, that is pancreatic tumor. Why do you think in this question I gave you this multiple episodes of hypoglycemia? What is the reason? Multiple episodes of hypoglycemia. What is the reason here? Anyone? Why do you think this patient is having multiple episodes of hypoglycemia? Hypoglycemia means blood glucose levels are being lowered down. Right? Yes, Ramen, you gave the right answer. The answer is because the patient must be having insulinoma. The patient must be having insulinoma. Insulinoma is a tumor in which insulin is being released in excessive amounts. And you know what is the effect of insulin? Insulin lowers the blood glucose levels, right? That is why hypoglycemic episodes are being seen. So this is what we are writing here, that the pancreatic endocrinal tumors would be seen in MEN1. Example, insulinoma. All right. Moving on, the third P is for parathyroid adenoma. Parathyroid adenoma. Moving on to M2. That MEN2 is divided into MEN2A and 2B. The 2A, as I told you, it will be having 2 P's and 1 M. Okay, so the 2 P's are number 1, parathyroid hyperplasia. So here we are talking about hyperplasia, not the adenoma. Then the second P is about the pheochromocytoma. Pheochromocytoma. The M is for medullary carcinoma of the thyroid. Medullary carcinoma of the thyroid, guys, you have to learn this. Remember in the same way that I told you. Alright. Then Hirschsprung disease. That is also a part of MEN2A. Remember this. It is also part of MEN2B, but Hirschsprung disease is more commonly seen in case of MEN2A. Okay. The MEN2 syndrome is associated with the mutations of RET. Okay, and RET is a oncogene. Moving on, MEN2B. Number 1 is medullary carcinoma of the thyroid. Number 2 is pheochromocytoma. Number 3 is the mucosal neuromas. Number 4, marfanoid habitus, that is very tall stature. Arachnodactyly means tapered fingers. right? These are all the parts of marfanoid habitus and ultimately Hirschsprung disease. Hirschsprung disease. All right. Now, I'll tell you a clinical scenario here. Supposing a patient comes to you, he's a diagnosed case of medullary carcinoma of thyroid. He's already a diagnosed case of medullary carcinoma of the thyroid. Okay. First of all, you tell me from which cells the medullary carcinoma of the thyroid is arising. Yes, what is the cell of origin of MCT? What is the cell of origin of MCT? What do you want to answer in this question? Hmm? Exactly, parafollicular C cells. The answer is parafollicular C cells. And what is the tumor marker? Guys, I told you, please review the tumor markers and the IHC markers. They are very high yield. Okay, so what is the tumor marker for medullary carcinoma of the thyroid? Yes, Paras, you gave the right answer. Fine, yes, that is the calcitonin. Calcitonin is the tumor marker for medullary carcinoma of the thyroid. All right. Now here comes the clinical situation. This patient was already being diagnosed with medullary carcinoma of the thyroid. The surgeon prepares the patient for thyroidectomy. Okay. The surgeon is preparing the patient for thyroidectomy because he wants to get rid of the tumor. But what happens when the surgeon begins the surgery? When the surgeon begins the surgery, patient's hemodynamic status is worsened. That means his blood pressure is shooting high. Okay, so what is this situation that we are talking about? Okay, you are the surgeon, patient of medullary carcinoma of the thyroid comes to you without doing any further investigation. You get the patient for surgery, and while you start the surgery, the patient will become hemodynamically unstable. What is the reason? So this is the practical aspect here. You guys are right. No, this is not thyrotoxic crisis, okay? Some people are saying pheochromocytoma. So can anyone explain me what is this situation that we are facing here? What is the situation that we are facing here? Anyone? Exactly, Angad, you gave the right answer. So what happens is, normally what happens, whenever the body is under any kind of stress, so fight and flight response, fight and flight response, there is sympathetic activation. Sympathetic activation, that means if the patient is stressed out, frightened, etc. Okay, there is sympathetic activation. Sympathetic activation. Now, what is being released as a result? Catecholamines. For example, epinephrine, norepinephrine, catecholamines are being released. This is what happens normally. Okay. Now, supposing the patient is having pheochromocytoma. So the pheochromocytoma is the tumor of adrenal medulla. So tumor of adrenal medulla is pheochromocytoma. So what will happen? If the patient is in stress due to any form, the stress may be physical stress to the body, or the stress may be psychological stress, mental stress. Okay. Physical stress to the body, one of the reason is surgery. Surgery is a kind of physical stress to the body. Okay. Now, what should happen normally? As it is a physical stress, what is going to be released? Catecholamines. Normally also catecholamines are released, but if the patient is already having pheochromocytoma, a catecholamine surge will be seen. Huge amount of catecholamines will be released. For example, norepinephrine. If huge amounts of norepinephrine they are being released, so this is the integration from ANS, okay, autonomic nervous system. Can anyone tell me that norepinephrine works efficiently on which type of adrenergic receptor? Anyone? Norepinephrine is having maximum effect on which type of receptor? How do you answer this? The answer to this question is alpha 1. Norepinephrine is having maximum effect on alpha 1 receptor, and as you know that alpha 1 stimulation leads to vascular smooth muscle contraction leading to vasoconstriction. Vasoconstriction, and obviously vasoconstriction is taking place, blood pressure will rise up. Okay, so imagine if huge amounts of catecholamines or huge amounts of norepinephrine they are coming in the circulation, blood pressure will shoot up. Okay, so if you don't rule out pheochromocytoma before going for a surgery for the medullary carcinoma of the thyroid, you're gonna end up you're gonna land this patient into hemodynamic instability. Okay, so know this point that always rule out pheochromocytoma in a patient who is already having medullary carcinoma, right? Know this. Moving on. Yes, so look at this picture. What is shown in this picture? Anyone? What is shown in this picture? Can anyone tell me? Looking at the picture, I'll zoom in. So look here. What you are able to appreciate. Someone is saying Paget disease. Why? Again. Yes. No, this is not ureterocele. Guys, this is lead pipe appearance. Okay, lead pipe appearance of the colon. In which condition do you see lead pipe appearance of the colon? Anyone? Lead pipe appearance of the colon. This is seen in case of ulcerative colitis. Ulcerative colitis. Now comes a very high yield topic. You should always know how to differentiate ulcerative colitis from Crohn's disease. Okay, so this is your homework. Please know this. I will also teach you, but just review it again. Okay, how to differentiate ulcerative colitis from Crohn's disease. So lead pipe appearance of the colon. Why do you see it? What is the reason here for the lead pipe appearance? The reason is that the colonic hostrations are being lost here. Loss of colonic hostrations. This gives the lead pipe appearance. Alright, and this is seen in case of ulcerative colitis. Similarly, if I change the wordings here, in which condition you see lead pipe rigidity? Give me an example. Lead pipe rigidity. Anyone? Lead pipe rigidity. So we have cogwheel rigidity, okay? That is seen in Parkinson's disease. Then we have lead pipe rigidity. Lead pipe rigidity that you would be appreciating in case of. Yes. So I'll give you an example here. Lead pipe rigidity, the patient is also having increased body temperature. And the patient was taking metoclopramide. What are we talking about here? Yes. A patient coming to you with lead pipe rigidity, body temperature is increased, and patient was taking metoclopramide. So what is this condition? This is a neuroleptic malignant syndrome. Okay, neuroleptic malignant syndrome. Know this, guys. So when you talk about drug-induced hyperthermia, you usually have 4 types of differentials. Okay, so number 1 is serotonin syndrome. Serotonin syndrome means if you combine 2 or more serotonergic drugs, then there would be increase in the body temperature, hyperreflexia would be there, muscle tone will increase, autonomic instability will be seen. All right, gut motility would also increase. Then when you talk about the neuroleptic malignant syndrome, if you are giving a patient a drug that is blocking the dopamine receptors, okay, it could be antipsychotics which block the dopamine receptors. It could also be metoclopramide, which is also blocking the D2 receptor. So the patient may end up having neuroleptic malignant syndrome in which the body temperature is also increased. All right, and there are other features seen in neuroleptic malignant syndrome. Third differential is, yes, malignant hyperthermia. Excellent, malignant hyperthermia. All right, and the fourth one is, what is the fourth one? Fourth differential of drug-induced hyperthermia. Anyone? What is atropine? What is atropine? Atropine is an anticholinergic drug. Anticholinergic means against parasympathetic. Parasympathetic stimulation increases all the secretions in the body. Atropine would act in the opposite way. So all the secretion in the body would be reduced. For example, salivary secretion reduced. So the patients, if they are having atropine toxicity, they would have dry mouth. Similarly, the sweating would also be inhibited. So sweating, if it is less, obviously the body temperature will raise, because sweating is a way of kind of heat loss mechanism by the body. All right. So this is how the body kind of loses heat. So sweating, if it is not there, so body temperature will be increased. So atropine toxicity could also be one of the cause. All right. And atropine, what is the effect of atropine on the heart rate? Can anyone tell me this answer? The effect of atropine on the heart rate? Yes. So guys, when you do this ACLS course, they always teach you about atropine. Why do you give atropine? Because atropine is going to increase the heart rate. That is why atropine is given for bradycardia. Okay. So the patient is having bradycardia, atropine could be given because atropine increases the heart rate. All right. This is a very important concept. Okay. Now, let us do the difference between the Crohn disease and the ulcerative colitis. This is very high yield. Okay. So Crohn disease, number one, the most important point here. Crohn disease could include, it could involve any part in the GI except for rectum. Okay, so everywhere it could happen in the GI tract except for rectum. Okay, so rectal sparing is seen in case of Crohn disease. This is a very important point. Mark it. Then, what is the most common site of Crohn disease? Your answer is terminal ileum. Terminal ileum or colon. All right. But when you talk about the ulcerative colitis, as you see, the name is ulcerative colitis, right? Colitis means inflammation of the colon. So it is going to involve the colon. And what is very peculiar point about it, that ulcerative colitis will always involve the rectum. So rectum is always involved in case of ulcerative colitis. Rectus is spared in case of Crohn disease. All right. Then skip lesions are present in case of Crohn disease. Continuous lesions are present in case of ulcerative colitis. Then transmural inflammation. All the layers are involved. Transmural inflammation is seen in Crohn disease. Mucosa and submucosa only in case of ulcerative colitis. Then you also see non-caseating granulomas. Non-caseating granulomas means the granuloma is having central necrosis. Alright, these type of granulomas are seen in case of Crohn disease, but not in case of ulcerative colitis. So no granulomas in ulcerative colitis. Moving on, Crohn disease patients, they have increased incidence of calcium oxalate stones. Calcium oxalate stones. So let us discuss this concept also. Can anyone tell me, why do you think Crohn disease patients, they have increased incidence of the calcium oxalate stones? Anyone? Why Crohn disease patients, they are at increased risk of having calcium oxalate stones? So this is also a very important question. Calcium oxalate stones. What is the reason? Can anyone tell this? Why do we write the risk of calcium oxalate stones is increased in case of Crohn's disease? Anyone? Can anyone answer this question? Yes? Now let me explain this to you. So supposing someone is having Crohn's disease, you already know that there is malabsorption in Crohn's disease because it is an inflammatory bowel disease. There is inflammation going on. All right. So what is going to happen? There is going to be fat malabsorption. So free fatty acids, they are there. Free fatty acids. Okay. Normally, what has been seen that whatever food products you consume that are rich in oxalate. Can you tell me an example of oxalate rich food product? Any food product rich in oxalate? Yes. For example, chocolate. For example, chocolate. Okay, so supposing someone is consuming huge amounts of chocolate, whatever oxalate that is coming, that is getting absorbed from chocolate, free oxalate, that is bound to calcium. Calcium is doing the duty of binding to free oxalate, okay, and making it in a bound form. So that means free oxalate is reduced. This is happening normally. But in a case of Crohn's disease, free fatty acids are increased. So if free fatty acids are more, calcium will be actually deviated towards binding to free fatty acids. So it's like oxalate was in relationship with calcium previously. Now calcium is attracted to free fatty acids, and calcium is now going to bind with free fatty acids. Since calcium is binding to free fatty acids, there is no one to bind to oxalate. So we have free oxalate increased. And this free oxalate is going to come out via urine and ultimately it is going to precipitate. It is going to precipitate. This is the reason why Crohn's disease patients, they are at increased risk of getting calcium oxalate stones. Okay, know this point, guys. Moving on. ESCA antibodies, they are being present in case of Crohn's disease. In case of the ulcerative colitis, we have PNCA or MPUNCA, and it is associated with a condition known as primary sclerosing cholangitis. This is very, very important. Primary sclerosing cholangitis, PSC equal to UC. So you remember it like this. PSC equal to UC, all right? Moving on. So look here. So supposing this patient is having an ovarian tumor, the patient is also having free fluid in the peritoneal cavity, that is the ascites, and the patient is also having pleural effusion, that is fluid being present in the pleural space. What are we talking about here? Anyone? What are we talking about here? Yes, so this is Meague syndrome. This is Meague syndrome, all right? And Meague syndrome is seen in case of ovarian fibroma. It is seen in case of ovarian fibroma. Know this point, guys. This is important. Meague syndrome. All right. Moving on. Look at this picture. So what is shown in this picture? Anyone? What is shown in this picture? Can anyone answer this? Looking at this gross image, first of all, let me tell you this is liver. Okay. So looking at this gross image of the liver, what is this? Let me see who can answer this. Yes, Dhara, you gave the right answer. This is nutmeg liver. Okay, so know this picture. This is nutmeg liver. And nutmeg liver would be seen in any case where you see the congestion. Okay, hepatic congestion is there, then you see nutmeg liver. So nutmeg liver, because the liver is resembling like a nutmeg seed. This is due to hepatic venous congestion. And hepatic venous congestion could occur in two main situations. Number one, right-sided heart failure. Okay, right-sided heart failure. Number two, Budd-Chiari syndrome. Budd-Chiari syndrome is hepatic vein thrombosis. Hepatic vein thrombosis. All right, now let me explain you this concept here. Why do you think a patient of right heart failure will develop nutmeg liver? What is the reason? So I'll draw a picture so that you can understand this concept. So supposing this is liver. Okay, this is liver. Now the dirty blood from the liver. The dirty blood from the liver is being drained by which blood vessel? Who is taking away the dirty blood from the liver? Yes, the answer is IVC, inferior vena cava. Inferior vena cava. Okay, similarly, SVC is also pouring the blood into right atrium. So this is right atrium, right ventricle, left atrium and left ventricle. IVC takes the blood from liver and ultimately it pours it into the right atrium. Now, right atrium, the blood ultimately will enter the right ventricle, ultimately into the pulmonary artery, ultimately into the lungs. From the lungs, via pulmonary veins, the blood will enter the left atrium. This blood is deoxygenated. This blood is oxygenated. Okay. Now imagine if someone is having a right heart failure. If someone is having right heart failure, this part of heart is not working properly. So the forward flow of the blood from the right heart, that is being interrupted. So what is going to happen? The blood will start to accumulate in the heart and there will be congestion. And ultimately there will be a time in which there will be backflow of the blood from the right side into the IVC. Okay, so if there is backflow of the blood into the IVC, what is going to happen? Liver will be congested because in the liver, the blood is not getting drained anymore because the blood is coming back, right? The right side of the heart is not pumping anymore. It is not working properly, right? So there will be hepatic venous congestion. All right. So this is very, very important. So hepatic venous congestion, that is the reason why it takes place in the right heart failure. So guys, it's very important that you understand what is the consequence of right-sided heart failure and what is the consequence of left-sided heart failure. In case of left heart failure, as you see, what is going to happen? If left atrium is not able to pump blood efficiently into the left ventricle and ultimately not into the aorta, all the blood will start the backflow. And where will the blood go? Where will the blood go? The blood will enter the lungs. Lungs. So guys, whenever you see a patient who is having left-sided heart failure, you will see pulmonary edema. Pulmonary edema, the patient may have breathing difficulty, the lungs are congested, okay? Because the blood is going back into the lungs in case of left heart failure, and the blood is going back into the liver, particularly not just the liver, but here we are talking about the liver because I had to teach you about the hepatic venous congestion. So liver congestion in case of right heart failure, all right? Yes. So this is very important point. Know about it. Okay. So this was about the images that I had to show you today. Now write down the topics that I told you. I'll make you write few topics that are very important for the upcoming exam. So you can review them. All right. So number 1. So write down the important topics here. Important topics for NEET PG. Number 1. Antipsychotics. Number 1, antipsychotics. So you should know A to Z about antipsychotics. First generation, second generation side effects, which antipsychotics are associated with maximum metabolic side effects, which antipsychotics are associated with maximum EPS. Okay, all these points regarding antipsychotics. Then second topic that is very important for you, just a second, all the vasculitis, the types of vasculitis, that is very high yield. All right. Then third one, in case of forensic medicine, you should know the names of, and along with the pictures, you should know the names of all the seeds of the toxic plants, okay? So toxic components, the seeds, the pictures, they are important. And you should know the active component of the poison. So poisoning is really important. Then we're going to talk about the stroke. So you should know different types of stroke depending on the vessel involved, what will be the presentation, okay? So Dr. Mac, I read your message. Definitely I'll make a video regarding the preparation strategy, okay? I'll make that video and upload it. Till tomorrow I'll do that. Then talking about the celiac trunk branches. Branches of celiac trunk. They are also very important. Then talking about the anatomy of anal canal. That is also really important. The hemorrhoids. Hemorrhoids. You should know the different types of hemorrhoids that we have, internal and external. Okay, then hydrocele, varicocele. Varicocele. Hernia types. Hernia types. Types of tracheoesophageal fistulas. Types of tracheoesophageal fistulas. All right. Then oxygen hemoglobin dissociation curve. Oxygen hemoglobin dissociation curve. G2, after this lecture, okay, I'll upload the link for my Telegram channel. Just after I stop streaming, I'll upload it here, okay? So oxygen hemoglobin dissociation curve. Number 12, the capnography waveforms. In anesthesia, you should know about capnography waveforms. Talking about the next important topic. Cannula sizes, I already told you. Okay, there is no way that you're gonna ignore this topic. This is very important. Cannula sizes and the flow rate. Cannula sizes and the flow rate. Then you need to know the composition of ringer lactate. Very, very high yield. Ringer lactate composition. Alright. Then we have something known as SHAD VAS score. Okay. Remember this. So this is regarding the indications of anticoagulant. Okay. So this SHAD VAS score you need to know. Then JVP waveforms, very, very high yield JVP waveforms. These are all the topics that have already been asked. Then curb 65 criteria, very important. Curb 65 criteria. Curb 65 is regarding, if someone is having the pneumonia, okay, so in which condition you're gonna admit the patient, in which condition you're gonna put the patient in ICU, right? So curb 65 criteria is very important. Then metabolic and the respiratory abnormalities like the arterial blood gas analysis, arterial blood gas analysis. So looking at the blood pH, then PCO2 levels and bicarb, you need to know, okay, what is the arterial blood gas abnormality that is happening, all right? You should also know what Winter's formula. Winter's formula tells you if it is due to the corrected metabolic abnormality that is going on, or is it the separate disorder going on. Then we have something known as De-Becquey classification of aortic dissection. De-Becquey classification. This is also very high yield. Okay, Gurjeet, I'll make a slide for enterohepatic circulation in the next video, okay? I'll explain that to you. Then anticoagulants, guys, they are very, very high yield. So time and again, you have been asked regarding the anticoagulants. So know this topic really well. Moving on. Translocations, so I already told you, okay, you should know different types of translocations. Okay, urethral injury. Urethral injury. Very important. So you should know okay, what type of urethra is getting injured, anterior urethral injury, posterior urethral injury, differentiation, okay, how to do differentiate. Okay, then next is the muscles of larynx action. Muscles of larynx and action. Then rotator cuff. I taught you in the previous lecture, so please review it. Rotator cuff. All right. Then talking about the sleep. So know the different stages of sleep. You should know them. Then you should know how the different type of immunoglobulins look like. Okay, what is the structure of immunoglobulins or antibodies? Structure of antibodies. Shubham, right now I'm not taking a regular batch in an academy. Okay, so if subsequently I would be taking, I'll inform you. Okay, very high yield the eggs, the parasite eggs. So you should know, looking at the picture of the eggs, okay, you should be knowing that, okay, which type of parasitic egg it is. Then talking about the next thing, you should know the malaria life cycle. The life cycle. The hypnozoid form, schizoid form, all right. So these are all very important. Malaria overall is very important. Then tuberculosis, I already told you, India is having huge load of tuberculosis, so you have to review that also. Moving on. You should know about drowning. In forensic, you should know about drowning. All right. So you should know about the structures which, when obliterated, will become what? Like, for example, the ductus arteriosus. When it is obliterated, it will become the ligamentum arteriosum. Okay, so that is also very important. Then different types of uterine anomalies. Very high yield. So you see in previous years they have been asked. Okay, uterine anomalies like arcuate uterus, bicornuate, HSG findings. So you should know how to look at the HSG and comment on the type of uterus. So always do this. Then you should know about urinary incontinence, the types of urinary incontinence. All right. Then ectopic pregnancy, very important. Ectopic pregnancy. Please review it. And then the kind of question in which, supposing the female is being prescribed OCPs, if she misses a pill, okay, so how is she gonna counteract for that? How is she gonna compensate for that? Remember, if one pill is missed, two pills are missed, and more than three pills are missed, this criteria, you should know it. Next, the uterine prolapse stages. Uterine prolapse, very important. Then very high yield congenital adrenal hyperplasia. So guys, if you at least do these topics, I'm really sure that you're gonna score really good because these are very scoring. Have been asked several times. Congenital adrenal hyperplasia. So look at the list that I uploaded, that I made you write in the last to last lecture. Okay. There also I have made you write few important topics. Okay. So that's it for today. Fetal circulation. 35th fetal circulation. right? Know about ductus venosus, foramen ovale, and all those concepts. The pictures, okay, boot shape heart and all that, they are very, very important. Then, last one for today, STI kits. STI kits, really important. All right. Okay. So that's all for today. I'm going to see you in the next lecture. So prepare really well. At least do these topics and the topics that I made you write in the last class. You're gonna score really well. All right. And make sure you are, focusing on the basic concepts, and again you are looking at the topics that have been repeated. It's not the time to do the topics, the new things, but you should only focus on the previous year questions, previous year topics. All right. Bye bye. G2, I'm going to send you the link here.